It's gonna go on my personal
Live.
Facebook page.
We're live.
Oh my gosh, it went on my personal Facebook page instead of Airway Circle.
Can
How
you
do I
share? I
change it
think you
now?
can share from that page, Renata.
Here
Go
you
to your
go. I will
page
do that.
and then share it.
There you
Hi,
go.
everyone,
Let's
on
see.
Renata's personal page.
Oh no, this is what happens when I do this often. Oh, it's on. There you go. It's playing for me. Okay, welcome everybody. I will let Lauren introduce herself while I go ahead and I'll share this in the correct page. I'm so sorry I did that.
Sure,
Yes, it's
hi. Well, thanks, Renata,
Okay.
for having me and Dr. Ben. But my name is Lauren Gueits. I'm so thrilled to be here at Airway Circle. I've been watching all of your wonderful interviews and learning a lot. So thank you, Renata, for what you do. But I'm on a similar track. Really, I want to raise airway health awareness to not only to dental practitioners, but to medical practitioners as well as patients or consumers, whatever you want to call them. But it's so important and there's so much to learn. So I'm here to help people learn and to help implement airway health into dental offices, from assistant to hygienist, financial team to doctor, pedodontist, even orthodontists. And we set up a digital platform called Airway Health Solutions, where we teach doctors how to implement and integrate airway as part of daily dentistry, not as a huge undertaking, so to speak, but just part of what you see and what you prescribe on a daily basis. So it's hard to say it in a nutshell, you know, everything you do, but I'm thrilled to be here. Thank you.
Well, welcome everyone. It is not Friday, it is Thursday night, and we're not doing Clubhouse tonight because it's such a special speaker that we wanted to make sure that we brought this live with some amazing visuals for you guys. And right before we came live, I was just telling Dr. Ben and Lauren that I have watched Dr. Ben speak a couple of times, and seriously, he is one of the best speakers in the airway industry I have ever been a part of. Whatever I heard years ago, to this day, I remember word for word of what he said, because he just has this gift of teaching and explaining in such a way that it just makes sense. So thank you so much for being here and accepting our invitation from Airway Circle. We're all about connecting, collaborating, and sharing what we know to empower mothers out there so they can take care of their children, and know that whenever they go see a provider, they have a little bit more knowledge. And we're here to empower also other professionals to feel comfortable asking questions and sharing and learning together. The more we share what we know, the better professionals are going to be out there. And it's really going to change the way that really other professionals that, you know, are not into airway yet see what we do. So that's pretty much what Airway Circle is, trying to gather everybody and bring awareness to all of these issues. Anyways, I'll stop babbling. Thank you guys so much for being here. Really appreciate it. And I'm going to pass the mic to Dr. Ben.
Well, thank you, Renata, for that wonderful introduction. That was very nice. I appreciate it. I'm sorry you've had to hear me speak more than once, but thanks for coming again to the meetings. So I'm really happy to be with Airway Circle tonight. You know, we certainly have things to share. You know, I've had the opportunity to treat patients young and old and in between for now 18 years based on growth, development, sleeping, breathing. And the biggest difference is that you're no longer staring or focusing at the teeth. And so, you know, 10 years of dentistry before this was tooth centered and tooth focused, and, you know, you're doing everything to help teeth, and it was rewarding and fun. And, you know, it was just different, but I didn't know what I was doing at the time, really. So 10 years in, I started kind of this pathway, and it's taken me down a whole nother road. And, you know, what was just treating patients in different age groups became significant enough to share it. And so now I'm at the point where I'm trying to share it with as many people, you know, that will listen and then take it back to their practices. Recognizing the change you could make is really unbelievable. You start out with, you know, a career where you spend 10 years working on teeth, and you can help people, and it's also, you know, good. But after that, the change became, well, instead of just fixing the mouth, now you're actually fixing the human. And so now you're fixing a human being, you get to help someone heal. So the difference was unbelievable when we start seeing, okay, we look for different symptoms and we look at different things, we measure different things, we figure out what can we do to help. And next thing you know, you're working your way down the growth and development pathway. And down that road comes an opportunity to help a child, a teen, or an adult grow and develop. And with that comes changes in the symptoms that they present with. And so you start to recognize if you heal the mouth, you heal the human. So we've had a tremendous impact on, the patients, and with the changes that we see, my entire team, just can't get over the differences that have changed from, working on teeth only to working on the whole entire head and neck area. And so it's been a great opportunity for me, my team, my office, my patients, but it's such a small little world. I'm one little dot on the map in Westchester County, New York. So you can only have an effect on so many people. I'm in a small little area. I can only see so many people. And so then you start thinking about, well, what about everybody else? Because I can't treat everybody, and I can't even get past my little community. So it seemed like a really natural progression to partner with Lauren and, have this educational platform put together to teach other doctors and their teams how to bring this to their practices and help the patients in their communities. And we've made some really good progress in the last few years.
That is fantastic. One of the things that I remember very well you talking about was about venous pulling. Would you touch a little bit on that? If a mother knows that their child has bags under the eyes, what does that mean?
Yes. So the changes under the eyes are a significant symptom for underdevelopment. And so anytime we see a child with that blue or purple discoloration under the eyes, that fancy word of venous pooling is what that is, but it really is an indicator for an underdeveloped maxilla. And so when the upper jaw is underdeveloped, it changes how, how we're breathing, which has an effect on the blood and the vessels. So I'm going to try to give this a short version because I don't want to spend an hour teaching the mechanism, but I'm going to do it, I think, in a couple of minutes. Basically, with an underdeveloped maxilla, the compromised nasal breathing delivers mouth breathing as compensation. When we're mouth breathing, what happens is it alters the CO2 levels. So mouth breathing tends to result in lower levels of CO2. So all of a sudden, mouth breather dumps out the CO2, so they have less of it. But CO2 is actually a vasodilator, so it opens vessels. It helps open vessels. So when we're mouth breathing and we have less CO2, the vessels constrict. But when our blood vessels constrict, it slows the blood flow. And if you slow the blood flow through the veins, if that vein blood sits too long, you start to see a discoloration. Basically, the venous or vein type of blood is carbon dioxide full. So with mouth breathing, when the vessels are constricting, the blood is going slower. But it just so happens under the eye, it's a very superficial vessel. So that inferior orbital vein goes right under the eye there. And if the blood flow is going slower through that vessel, then the carbon dioxide is there longer. And what happens is it starts to show as a tint of purple or blue. Basically, it's the color someone changes when they have poor breathing, less oxygen. And under the eye it's like the only place we could see it because of the vessel, and it becomes a great indicator. So when you're thinking about seeing venous pooling, it should trigger, the following things. I see a child with venous pooling, I'm thinking underdevelopment. So now we've got an underdeveloped maxilla. See a child with venous pooling, I'm thinking they have some sort of airway compromise. And it's probably a combination of some nasal airflow resistance, or they struggle to breathe well through their nose, and there's mouth breathing going on. Now you put it all together, you're going to have some kind of sleep disorder breathing going on. None of that adds up to OSA because you can't really say OSA until there's a sleep study that diagnoses it. So we don't really talk much about OSA as being the issue. Really, the issue way before OSA is, do you have some sort of nasal airway compromise? Do you struggle to breathe through your nose? Are you breathing through your mouth a little bit? Are your jaws underdeveloped? Because if your jaws are underdeveloped, you've got a level of airway compromise. It doesn't matter really if it's just some mouth breathing or a little snoring, or is it all the way to OSA? You still have to treat the cause, which is the growth and development in the jaws. So we use that venous pooling as a diagnostic tool to teach parents that, well, we have to talk about the jaw development. We have to talk about the sleeping, the breathing. We want to ask more questions. Usually, since that's one of the first things we see, it generates forms to fill out because now we're asking more questions. We're looking to learn more. We want to know more symptoms. How are things at home? How is the sleeping? Because, you know, if you go back 18 years, even 15 years ago, you know, I would have laughed if someone said to me 15, 18 years ago, do you ask the parents of the children that you're seeing how they are sleeping at home? Can you imagine that 15, 18 years ago? You know, here I am working on teeth at that point. I would have laughed myself and fell down. But the idea is today, it's like the first thing we start doing is we start asking about, once we see the children and meet them and start, you know, witnessing what's going on, we start asking about the sleep. How are they sleeping? And then from there, you know, the list keeps growing and growing. So venous pooling is a big indicator. And these kids are coming to the dental practices, right? The children are coming in twice a year. We have them being screened for cavities and for other things, getting the prophy, spending time with the hygienist, learning how to brush your teeth, flossing at appropriate ages. So we have all these fun things going on. We're mostly playing with them, but since they're there and we're seeing them every 6 months, what a screening you could do to help see if a child needs, you know, your attention in the growth and development department, which, you know, sadly, I have to say most kids need the help.
Definitely. I have some questions coming in already.
Sure.
And guys, if you have any questions, please either put on our Facebook Live. I got my phone right here, so I'm checking them, or on our chat over here. But if you're watching this on Facebook, please hit like or the little heart or share with your friends so more people can get to this video. Also, we are doing a takeover week on Instagram for Airway Circle. So everybody that's a team member are taking over our stories, and we're doing giveaways. So every day, today was Ruth, yesterday was Lael. So we're going to ask some questions, and whoever answers the question correctly will get a prize. So make sure you have watched our stories. We already did the one from me on Clubhouse on Tuesday. But before I go to this question, I would like Lauren to touch a little bit on the screening. So as a hygienist, can you talk a little bit about what can hygienists be doing right now, even if they don't want to go full into myofunctional therapy? What can a dental hygienist be doing right now to help?
Well, amazingly, Renata, they already are doing it. They're just not aware of it. That's the funny thing, because when you do your oral cancer screening, you really are doing an airway screening. You're just not connecting the dots. You're looking at the soft tissue. You're looking at the tonsils. You're looking at the tongue. Everything that you're doing in the oral cancer screening is basically an airway exam. So I'm a big fan of acronyms. So I like 5 clues during your airway screening, and that's during your oral cancer screening, and it's NESTS, N-E-S-T-S. So the first thing when you do your oral cancer screening, you're looking at the palate, you're looking at the roof of the mouth. You can't help but notice if it's narrow, that's the N for nest. So we're gonna look for narrow arches, which is a vaulted palate. Immediately, if you see that, you have to just tie in that it's underdevelopment. Forget about sleep apnea, forget about obstructive sleep apnea, forget about all the diagnosis. Just raise your awareness to, hey, this isn't normal. And if I have a high vaulted palate, I basically have what Dr. Miraglia refers to as like a homeless tongue situation, right? There's no home for the tongue. So if there's no home for the tongue, they're going to have problems breathing, and you can see the underdevelopment just from looking at the palate. So N, narrow arches. Then E, when you ask them to stick out their tongue and you look at their tonsils, you are looking in the oral cancer screening. If they're enlarged, that's another clue. Now, there are ways you can diagnose them on a scale of 1 to 4, but it's not necessary. This is a hygiene screening. This is just to raise your awareness, to then tell the doctor, say, hey, I really think this patient would benefit for a full consultation, full airway screening if you don't have the time to do it. But let's get the ball rolling. Let's get the conversation started from the hygiene chair so the patients don't feel a disconnect when the hygienist sees something but doesn't say something. The doctor comes in, sees something and says something, and then the patient's like, well, why didn't she or he say something, the hygienist, right? So there's lack of trust. So you all have to be on the same page, but the good news is it's not that difficult. And I think that's where everyone kind of goes down this rabbit hole of it's intimidating. It's so but it's really not. Just be aware of underdevelopment. So narrow arches, N, enlarged tonsils, E, soft palate is the S. You're looking at the soft palate. I think most of us are aware of Mallampati score by now, but if you're not, it's really not that complicated. We're just going to measure the on a scale of 1 to 4, how much of the soft palate. If many times you can't see the uvula, there you go. Let's see.
I'll show.
First score, okay.
I'll model.
So, yeah. So if you're not familiar with it, it's so easy to Google. It's so easy to understand. And I'm happy to provide more training on this on a different webinar, actually going through all this. But at least you can Google it and see the soft palate can give you a Mallampati score. The T is for tongue tie. Okay, so when we do our oral cancer screening, we ask the patient to raise the tongue to roof of your mouth. If you can see that they're having a really hard time doing that, or that they close their jaw while they're lifting because they can't get that a nice wide opening, you can screen for a tongue tie. You can't really screen for a posterior tongue tie quickly, but if there is an obvious tongue tie, you'll be able to see that and just take note. And then the S, I think, is scalloped tongue, because you're still doing the tongue exam. When you stick your tongue out and you're looking at the lateral borders for any lesions, you can't help but notice the scalloped tongue. And scalloped tongue is its own risk factor for obstructive sleep apnea. So just those 5 things, nests, I think they're a good start to get the ball rolling. Hopefully everyone's already doing oral cancer screening. So I hope this isn't something, oh, I don't have time to do. So you're basically doing your oral cancer screening, but with your Airway goggles on. So it doesn't take any more time. It just takes a different awareness to do the same thing, but be a little bit more efficient. And who's better at multitasking than hygienists, right?
Definitely.
They're known to do that. So that's as far as the screening goes. And listen for clues. So you have your Airway goggles on, but put your Airway ears on. When I hear cold sensitivity, I used to think, okay, I need to do my, MI paste or fluoride varnish. Now I think Airway. That's a huge clue for Airway. So how can you get from cold sensitivity to Airway? Well, you have to trace to the why. You have to keep asking, well, why do you have cold sensitivity? Oh, because I have recession or fractions. Well, why do you have fractions or recession? Oh, well, I have narrow arches. So then I'm colliding rather than sliding, and you're causing that damage. But it all stems from underdevelopment. So you can even trace cold sensitivity all the way back to Airway. And that's where the patient all of a sudden gets that, aha, the light goes on. Like, oh my God, Lauren, no one's ever told me that. People say I brush too hard. And then all of a sudden they think you're like psychic when you start to talk about other symptoms, right? I know Dr. Scott Province is on, and he was saying how that's what happens. People start to think you're psychic when you dive into the symptoms that they never correlated to be an oral or an Airway issue.
Definitely. And I have seen a lot of people who complain also of cold sensitivity. They don't swallow for example, cold water correctly. They usually do this. The water goes in the cheeks first, so then it really touches those areas.
Right.
And you're supposed to just hold water in the palate, and the tongue is supposed to go back. So you're not really supposed to be putting liquid in your cheeks. Just changing that, even though you have recession or some issues like that, might help a little bit. So let's go back to Dr. Thank you so much, Lauren. That was perfect. Go back to Dr. Ban. And Dana had a question. Whenever you're talking about venous pooling, she said, what if you have a nasal breather that has puffy eyes? Not necessarily purple or blue, but puffy.
Yeah, so just being a nasal breather isn't enough. That airflow has to be without resistance. So non-resistant nasal airflow. So you can be a nasal breather and still have airflow resistance. There's a threshold where the mouth starts to open. So mouth opening is compensation. If the airflow through the nose is really bad, then the mouth starts to open. So not everyone that has nasal airflow resistance opens the mouth. So what happens with that nasal airflow resistance is that As soon as you have nasal airflow resistance, you're going to have a difference in the balance of your carbon dioxide, your oxygen, and your nitric oxide. So when those three start to become an imbalance, and it doesn't even necessarily have to mean lower oxygen, because a lot of times the oxygen stays high enough, but it's the CO2 that drops too low and then the nitric oxide that drops too low. So a puffy eye can be part of an inflammatory process too. So you could think about, well, are we using the word puffy and it's swollen as well? Because then there could be an issue with an inflammatory process going on. That's a little bit different. But most of what happens with the discoloration in the eye has to do with the imbalance of the carbon dioxide and the nitric oxide, not as much the oxygen level. So you can have your oxygen up there at 99 all the time, but if your CO2 or your nitric oxide or both get a little too low from either nasal airflow resistance or the compensating mouth breathing, then you're going to show the discoloration there.
Perfect. Anne asked, have you used Invisalign for expansion growth in children under the age of 7? Totally different topic. If you're okay
not
going
under
there.
the age of 7. I have used clear aligners as young as 9, but not under the age of 9. I use different appliances there, some fixed expansion appliances. I don't use clear aligners for under the age of 9.
Since we're talking about expansion in children, would you touch a little bit on the other appliances that you like to use?
Sure. I'm a big fan of fixed expanders in kids, removable expanders in children. The compliance issue tends to, not result in good, accomplishment for growth and development. So I've gotten away from removable appliances that are in the expansion category. So if you think about expanders being fixed or removable, I prefer fixed for children. And I prefer that in the age of about 8 to 12. So between 8 and 12, fixed expanders are wonderful. I use both an upper and a lower. And so with an upper and a lower, you can gain a significant amount of expansion. I'm usually not putting a fixed expander in a child for less than 8 millimeters of expansion. So the expansions start at 8 millimeters and go from there. So is it 8, 10, 12, 14, 16, 18? Is it 1 or 2 rounds of expanders to get that amount? Because if you have a standard 12 millimeter expander, you're going to get 10 millimeters out of that one. And if the child needs more than 10 to get back to where normal would be, then you're going to use 2 of them in a row. One expander, exhaust it, then get the second one and exhaust that one, and you can get a lot of growth and development back. So fixed expanders are wonderful between 8 and 12. Between 3 and 8, there are removable guidance appliances, and so loosely they're myofunctional guidance appliances. Different companies make them. I use a fair amount of them from a company called MyoBrace. And so, there's myofunctional guidance appliances out there. MyoBrace makes them from age 3 through even the teen years. I tend to use them between 3 and 8 predominantly. The goal there is to redirect the breathing in the musculature so that you can get your growth and development back naturally. So the younger the child, the softer the bone, and the more agreeable it is to redirecting the breathing and musculature. So I'm a big fan of getting those appliances in early. The goal there is to get your nasal breathing back, get your tongue function and strength back, break up the activity in the lips and cheeks. And if there's a frenum issue, like Lauren was mentioning, release a frenum with myofunctional therapy. So those appliances are combined with myofunctional therapy. So from 3 to any age, the orofacial myofunctional therapist is a key ingredient to helping these children. So that's a referral for almost every kid. When you're getting involved with appliance therapy, frenum revision, myofunctional therapy, from 3 on up, you can redirect a child. The next thing you know, you're trying to avoid the expanders between 8 and 12. And then if you can avoid those expanders and you get your breathing and musculature back, you can just graduate through appliance therapy with your exercises and your work and kind of grow your face out all the way. And then just so everyone knows what our goal is 32 teeth, a fully grown human being. The goal is not 28. Anybody can deliver 28 teeth. In fact, you don't need your eyes open. You don't need to do much of anything to deliver 28 teeth. So the real goal is get the jaws to fully developed position so that the wisdom teeth can erupt into function. So there's a difference between not extracting wisdom teeth, meaning leaving them impacted, and having them erupt into function. So you have 32 in the mouth. So our goal is grow the jaws fully so that when the child is between 18 and 21, about that age, we're getting the wisdom teeth to erupt fully into function. That's the outside goal. That's not easy to do if you're not doing all of the things that are available to us. So all of the things, we're touching on them all now, right? We want some good nasal hygiene to breathe through our nose. We want to do frenum releases when they're indicated. We want myofunctional therapy for most kids need it. And then if you're working with guidance appliances, or if you're working with expanders, or a combination of the two, when you start putting this all together, then you start having the opportunity to grow the jaws enough to keep the wisdom teeth and have them erupt into function. So that's the outside goal, which is why we need all of these parts put together. It's a really nice collaborative care pathway to have a dental office and team work with a myofunctional therapist. And if you needed, you can include any type of surgeon who can do frenectomies. A lot of the dental offices do them themselves. Pediatric dental offices can do those. A periodontist can do it. An oral surgeon could do it. Anybody who wants to be trained how to do, the frenectomy appropriately can really be supporting good growth and development for the kids early on.
Perfect. Are there some measurements or numbers that you're looking at a child whenever you're deciding to do expansion?
Yes. Yeah. So the measurements begin right at age 3 when they first come in. And so there is some significant research in the pediatric literature that goes back quite a ways. And Dr. Bogue was his name, but he published that tooth A and J. So if we're thinking about the primary teeth, a 3 to 4-year-old, A and J should be at minimum 29 millimeters apart, bare minimum, because in his research, he learned that 28 millimeters, that's underdeveloped. That child never recovers to get all the teeth in. It becomes a crowded malocclusion and a really bad bite. And then the ortho and the rubber bands and the craziness is coming. So the idea there is 29 is like the bare minimum number to be considered you're about right. But if you think about age 4, I like 30 to keep it even. So I'm looking for 30 millimeters between A and J at age 4, because then I know that child's heading in the right direction. If you have 30 millimeters between A and J at 4, we're in good shape. So the 4-year-old who measures 29, 28, or 22 is underdeveloped and will not recover the distances. Now, age 4, if we're 30, we're good. Now, 30 is the minimum. So when we're thinking about a range, it's a 5 millimeter range would be nice. So 30 is the minimum, 35 is the maximum, meaning if you're 4 and you're between 30 and 35, we're in good shape. That's a window. Now, when you get to age 8, the minimum is 35. When you get to age 12, the minimum is 40. When you get to 18, you want to be 45. And so when you're thinking about age 4, 30 is the minimum, age 8, 35, age 12, 40, age 18, 45, then you can make your range. The range for the 4-year-old is 30 to 35. The range for the 8-year-old is 35 to 40. The range for the 12-year-old is going to be 40 to 45. The range for the 18, 45 to 50. Now, that little progression all the way up, it's a significant measurement from the minimum number, because when you're past the minimum, if you're in that range, that's the range for growth and development where most wisdom teeth erupt into function, meaning you're over the 50% mark erupting into function. Now, that's a big swing from where we are. So what I like dental practices to think about is you don't need my numbers. You think about your own. How many teenagers get their wisdom teeth out in your, community? So you think about your community. And if you're thinking about the teens, what is the wisdom tooth extraction rate? Is it 60%, 70%, 80%, 91.2? Is it 87.5? I don't care what it is. The idea is think about the wisdom tooth extraction range you have. Now, if you're thinking about that number and then you think about, well, look at these widths we would have to achieve to have 50% erupt into function. So it's a big swing from going from 75% are getting extracted to 50% are erupting into function. And that's accounted for in the width. The early growth and development is critical. So the sooner you get in and start to guide that growth and development, the sooner you can get those numbers appropriate. And then, like I mentioned before, 28 teeth is a no-brainer. Anybody can deliver that. It takes almost no effort to get to 28, okay? But you put just a little tiny bit of effort on top of that, and you should have your wisdom teeth erupting into function for the majority, and that's 51% or more of your patients. That's a really nice thing to do because you just helped a human being keep all their body parts. So I like to think of the wisdom teeth as body parts. And so it shouldn't even be called an extraction anymore. You should think of it as an amputation, because when you take a body part away, it's an amputation. So I don't like to amputate anything off the body. I wouldn't want it taken away from me. So I'm trying to keep teeth And the idea is there's nothing wrong with growing and developing appropriately and having all your teeth. So I think we should look at the wisdom teeth a little differently and see them as more critical than not.
Wow, that is so true. I stopped growing at like maybe 4 or 5. I
Yeah.
just saw
Yeah, you and me both.
oh my Lord, I saw a 5-year-old or a 6-year-old today, and she had a 32 from palatal to palatal. So on the inside, not the occlusal surface of the A and J,
Okay.
but and
Yeah, I
I think
used
I'm
the
a
measurement in
32.
between. I guess I should have
Okay,
clarified that. I'm measuring in between the teeth. So
perfect.
mine is all based on
Lingual
Dr. Bogue and Dr. McNamara. So when you think about Dr. James McNamara, the transverse measurement, he was one of the first to publish about it. The distance is in between A and J, and then in between 3 and 14. Because when you were beyond 6 years old, we're measuring the first molar, the permanent first molar. So I'm just measuring at the gum line, the shortest distance between 3 and 14. And that distance in between becomes that 30, 35, 40, 45 progression for showing normal kind of growth and development. The crazy thing is you don't meet people in the normal category. So overwhelmingly, we're underdeveloped, we're narrow, we're vaulted. And it bears when you start recording the numbers for patients that are coming in, you'll find very few that are well developed.
Yes, I can't believe I'm gonna show you guys this. It's such a dental person thing. I'm not sure if anybody else can relate. The amount of models
You
that
have
I
your
have
models.
saved. I have all of them. And the interesting thing is that I checked the other day the measurement, and I have grown about 2 millimeters. So just like keeping my tongue up, 5 years since I've been doing myofunctional therapy, or that I've known myofunctional therapy, and I've kept my tongue up, it's grown a little bit, about 2 millimeters. I still have ways to go, but
But every
came
little
in
bit helps.
handy. Yes,
Every
came in
little bit
handy.
helps. And that's
I
just
can
with myofunctional therapy. Did you do a Frenum revision too? Or just no Frenum revision? Okay.
Just keeping my tongue up and nasal breathing. I haven't done
Right?
anything
Excellent.
crazy.
Yeah.
But I can hear some dentists say, but 28 teeth, are enough. That's enough.
No.
Nobody really needs the wisdom teeth to chew because they're just looking at chewing.
Yeah.
Why? Why do we need extra room back there?
Yeah. I mean, you don't need teeth to chew. I mean, if we're looking at teeth for
Right?
chewing, I've seen people chew stuff without teeth. And then, so yeah, teeth are for chewing, yes, but technically you could get by without teeth for chewing. But you really need the teeth because with all of the teeth, you then actually have fully developed jaws. With all of the teeth, you have the proper shape and size for the tongue. So what happens with all of the teeth, in order to have them all appropriately, you did need to have the jaw development. Now, if you've got all the jaw development, then you have the proper nasal chamber. Then you've got the proper forward growth, so the air can pass through the nasopharynx, then oropharynx, then laryngopharynx. So all these fancy words for the regions of the airway. Basically, it's your nose has a nasal cavity. Then when you get past it, you've got your nose airway, you've got your mouth airway, and you've got your neck airway. So that's nasal and oro and laryngopharynx. But the idea is if your jaws are fully developed, there's more space for the air, and more space for the air means better airflow. So having all 32 teeth means you have fully developed jaws, but you also have the perfect chamber for the tongue. That's important because the proper swallow is a vacuum. Compression with vacuum is a great swallow. But if you have less than 32 teeth, you can't create a good seal. And so in order to really have a perfect swallow and perfect mechanism of working the oral cavity, you're supposed to have all 32 because that creates the border that the tongue compresses to then produce that beautiful vacuum of a swallow. Otherwise, if we're at 28 or 27 or 24, which there are some people at 24, we know those, bicuspids out, wisdom teeth out. The less teeth you have, the less you have the less ability you have get your tongue in your palate and make a great compression and seal swallow. Next thing you know, you're swallowing air. And when you start swallowing air on a regular basis, it creates a lot of disturbances all the way down the line. So you have a lot of trouble with swallowing air. So it's an endless list of things that can be symptoms downstream from less than 32 teeth. So we need 32 teeth, and it should kind of shift. We should have a shift in paradigm of, a human being is supposed to develop fully and have 32 teeth. So let's pay attention to that early enough to make sure we get that in the majority of patients. It'd be nice to swing from mostly extracting the wisdom teeth to mostly keeping them. That would be a really nice swing. And you'd end up swinging the overall health of those people by having more teeth, better development, and then next thing you know, the better function of the oral cavity. So yeah, a properly functioning oral cavity needs all the parts. It would be equivalent to say, you know, your car will be fine with 3 tires instead of 4. So 3 is enough, isn't 3? 3 is 75% of your tires. I mean, isn't that enough? But it doesn't work very well. You might be able to get down the road with some sparks and stuff. Well, that's what it is, 28 out of 32 teeth. You're malfunctioning. You're going to malfunction with 28 out of 32. It's very hard to be a properly functioning oral system if you're missing parts. So teeth are parts. We'd like to keep them all.
Love it. Somebody just said they couldn't see me earlier. I want to show you guys. I think on Zoom they can see me, but not on Facebook. I was just showing how many models I have kept over the years. I have everything you can imagine. But anyways, that's all I wanted to show. Dr. Scott just came up with a really good point. He said at 12 years old, when they are at 40 millimeters and you have them in retainers, will good oral posture get them to 45?
A 12-year-old who's at 40 is nice. And so the idea there is now 40 is the minimum at 12, right? Our range in 12 is 40 to 45. So at 40, we're in the minimum. Now, when you use the word retainer, that scares me a little bit because no one needs a retainer while they're still growing. So if you're supposed to be still growing from 12 on up, which you are, we shouldn't call it a retainer and we shouldn't be using a retainer. Whatever we're working on, it should be growing and changing with the child. So certainly having your proper nasal breathing, obviously having, if you're using guidance appliances, that's great. I think I see Scott just chimed in. It was a MyoBrace retainer, but MyoBrace, those guidance appliances, I don't know if retainer is the right word, because those appliances keep your breathing and your musculature in good balance and function. So technically MyoBrace it's not a retainer, it's a guidance appliance, because anything from MyoBrace will help your breathing and musculature to keep working for you. Now the goal is 1240 is a minimum, but if you have the proper nasal breathing and you've had your friend and released if it needed, and you have proper muscle balance, you should be growing on your own. By 12 years old, we're trying to wean the children off of those appliances to confirm that they are breathing and growing on their own. So usually by 12, we're getting down to wearing a MyoBrace type style, but 1 night a week. And the idea is to work our way down to 1 night a week and show that they're either the same or still growing over time, because then you've got the breathing and musculature going. So coordinating that with the myofunctional therapist to make sure that, okay, as we're using the guidance appliance less, if we've got the breathing and musculature going, you're supposed to be growing, just like that 12-year-old, just like their feet are going to get bigger, just like they're going to get taller. Their jaws should be growing, provided that you have breathing and musculature working in your favor. Now, if you start to wean off the appliance, but you're not seeing growth, or you see 40 go to 39 or 38, then the breathing and musculature are working the other way. So we still have then breathing and muscle dysfunction to work on. So weaning off the appliance helps to diagnose, are we continually growing thanks to good muscle function and balance, or are we going back a little the other way, meaning we haven't achieved proper breathing and muscle balance yet. So we don't necessarily just wear that appliance all the time and all day and all night indefinitely. You do try to wean children off of them to prove that they're growing on their own. Eventually, you want to get to the point where you have your great nasal breathing, their lips are sealed, they sleep through the night, the breathing is silent and invisible, the tongue, the lips, the cheeks, the chin, the neck, the face, everything is balanced, doing its appropriate position, job, etc. And then you have someone who can grow on their own without symptoms.
That is a perfect point, because we do have so many patients that get expansion and get a retainer, and then it stays there.
Yeah, so I'm a fan of expanders, and when I use them, they are fixed in children. And when I put them in and we give them their 8 or 10 or 12 millimeters, we're getting them caught up into the range they're supposed to be in at that age. So then we have to take them away. So we don't use expanders for a very long period of time. When you're thinking about the growth and development of a child, we might use expanders for 6 months to 9 months, but it can recover 8 to 20 millimeters depending upon what that child needed. Now, when you get your recovery, the idea is you're really supposed to have all of the other things in place, because guess what happens if you use expanders and you take them away, but you don't address the breathing or the musculature? The child's going to go back, because if you don't change the circumstances, you're going to have the reversal. So expanders don't change the breathing and the musculature, and they don't release a frenum. Expanders don't make your tongue behave differently. Expanders don't make your cheeks behave differently or your lips behave. So guess what's got to happen? You got to take those expanders away. We can transition into like a little myo brace, but that's only so that the myofunctional therapist can really take that child all the way. You need the orofacial myofunctional therapy to get the breathing right and the muscle balance, so that you can keep what you did and continue to go in the other direction. Otherwise, if you don't address the breathing and musculature, pretty much most expansion will fail and go right back, because the inside is weak and dysfunctional and the outside is strong and hyperactive. So if the inside's weak and dysfunctional and the outside is strong and hyperactive, you're going to ungrow. You're going the other way. You're going to shrink. So you go right back to where you started. That's a really common finding, by the way. In my practice, I almost have that consultation once a week, where a child shows up, second opinion. They had an expander, but now they're being told they have to take out the teeth. So it doesn't register with a parent, right? Wait, we did an expander to help make room for teeth, but now 2 years later, you want to take out the teeth that we were trying to help. So did the expander not work? So the parent gets in their head, they can't make it, they can't rationalize it. You can't wrap your head around it. It doesn't fit. You got, so they asked me, well, what do we do? And then when I measure those children and they're 30, and then we get their records or a model or a measurement, they were 30 before their expander. So they're 30 before their expander, they're 30 after their expander. That's a tough conversation to have with a parent, but I don't meet many children in those consultations who come in and their width is different than it was before expansion, which means they weren't paying attention to the breathing and musculature. And so an expander alone, just to move things and then take it away and have it go back, now you put a child through, a process that didn't have any gain. And it kind of proves the point that you really need the breathing and musculature. Otherwise, why are you doing that to the kid? So we see that a lot. There's a lot of that going on.
Perfect. Anne asked, in adults, how much dental velar extension can you achieve on average with Invisalign?
So with Invisalign or any clear aligner, you can get all of the uprighting that you would need, and you can expand the posterior until there is no anterior crowding. So it's hard to give a number because it depends on what you're treating. So if you have severe crowding, you need to move your back teeth a lot. So if your front teeth are mildly crowded, you probably only need to move the back teeth a little bit. So the idea is that if you have a patient that comes in and has mild crowding, you would be looking to upright the back teeth and align the front teeth. Now, if that resolves all the crowding, we have step one covered. We have the teeth fitting in. But is it wide enough? Then we're looking at the measurement, because you can still go wider. You're allowed to expand beyond crowding. So typically, expansion begins and ends at let's get rid of the crowding. But then we take one more look at, well, did we make enough room for the tongue? Do we have, good breathing, sleeping, et cetera? Because maybe we needed to go a little farther. So just because the crowding's going doesn't mean you're done expanding. So the bare minimum for any clear aligner cases, you will upright or expand the posterior segments until there is no crowding. So I'm not a fan of IPR, because it's like IPR is like mini extraction. You can take a whole tooth out or you can cut 10 of them. What's the difference? You're taking tooth structure away. So the patient doesn't need IPR. What they need is more movement. And so with clear aligners, you have a really safe and healthy and effective way to move posterior teeth. Crowding is present in the anterior teeth because the posterior teeth are wrong. When you address the posterior teeth, you get your crowding to resolve. But really, when you address the posterior teeth, you get your tongue space back. So when you get your tongue space back, good things start happening. So we like to expand or upright all of the back teeth until there is no crowding at minimum. Then we're paying attention to, okay, do we need to go further than the crowding? And that's okay, because sometimes we do, and we might get a little space here and there. Upper laterals tend to be a little small. Maybe you open up a 0.5 millimeter to 1 millimeter at the laterals. Sometimes you do have people who are missing the premolars. Then almost always you're going to get some space behind the canines, because you're trying to move the back teeth wider and the front teeth forward to open up, and it would be very natural for there to be space behind canines if premolars were missing. So I don't really have a number like, oh, the maximum is 6 or the maximum is 4 or the maximum is 7, Because once you get a tooth moving, you can just keep going. It really isn't a maximum, but it's like anything else. You're only trying to move the teeth where they belong. You're not trying to move them where they don't belong. So don't overexpand means, yeah, don't move the teeth where they don't belong, but you definitely need at bare minimum upright with no crowding in the anterior teeth and no IPR used to do it. Then you've moved your back teeth enough.
And Renata, if I just may chime in, there's been so much chat on the Facebook groups lately on clear aligners. And there's so much misconception out there that clear aligners can't fix malocclusions, that they're only meant for relapse, that they cause, all these problems from cases that have gone bad. I would just love for Ben, if you would just take an opportunity to just share how clear aligners are a wonderful tool, and it's really the technique. It's these poor clear aligners are getting blamed for all of these troubles, and it's a wonderful, wonderful tool specifically for Airway. So maybe you could just touch upon that.
Yeah, also. Absolutely. So yeah, that's a total misconception, and it's not unfounded because while clear aligners are absolutely amazing, you do have to have a nice technique. So depending upon your technique is where your outcome, ends up being. So because clear aligners are very capable with an incredible technique, you can develop an entire arch and you can really produce some wonderful, correction in the malocclusion category, in the TMD category, in the tongue space category, in the airway category. So you can resolve a lot of things. Clear aligners are not only very capable, but they're also very kind and gentle. The fact that they're removable means that your teeth and your whole entire dentoalveolar complex gets a break. There's a difference between something that is fixed like braces and the force is just constant and pushing a tooth through the bone versus clear aligners where the force is intermittent because they're on and off, they're on and off, they're on and off. When your teeth get a break and they're being moved and then so-called relapsing while the aligners are basically on and off, that's a different dynamic in the alveolus. And so, with a really nice technique, you can do wonderful things. And just like anything else, you can use the tool wrong and get an adverse effect. So when you're thinking about clear aligners, they're not like plug and play or it's instant. Just because you're using a clear aligner, you're going to get an amazing result or it's going to be, perfect. You really have to have a great technique with them. So if you have clear aligners and a great technique, you're going to see some things that are near miraculous. If you have clear aligners and you have a not so great technique, you could see damage because they can be causing harm if you're using them poorly or incorrectly. So I've been using clear aligners now for, I think, 17 years. And so it's either 17 or 18 years now. And I have, it's over 1,000 cases treated in there. I don't even know the number anymore. But the idea is I don't have a single adverse outcome, not one. I have a 100% patient satisfaction rating. I have a 100% completion rating of treatment. I have 100% right across the board of happy patients who have really successful results. I never had to take a clear aligner case and use braces to finish it. Never had the things that are out there are in my world, it's kind of weird that would happen to someone with a clear aligner because I want to use it on everything and it can be very successful. But it's part of the reason why I'm teaching because I guess just because I got it, this outcome doesn't mean everybody did. So now here we are teaching because why shouldn't everybody get a really nice outcome? So clear aligners are the answer for most things malocclusion and airway, and they make a really big difference in the oral cavity. And it's a really good choice for patients to be using.
Thanks. I know that was a hot topic, Renata. Have you seen that on some of the message boards?
Oh my gosh. Even where I worked over here, if we looked at a patient and he needed a little bit of movement, you're good for clear aligners. But if you need a lot of movement, nope, we cannot even try it.
Yeah.
So
in my world, it's the opposite. When we see patients who need a lot of movement, we think it's got to be clear aligners. You shouldn't have braces.
Wow.
Braces aren't wonderful with a lot of movement. They cause more damage.
That is so true. Somebody's asking over here, what are you using to Nicole, to easily measure the palatal margin to margin? And somebody asked if it's from CEJ to CEJ. So Angela said about the caliper, digital caliper. I got this on Amazon. Super easy. I'm not sure if this is what you use.
That caliper is great. I've got I have the base model. It's just a Bowley gauge that you slide across like that. It's got the two forks.
Perfect.
And you separate it. It's a ruler. You do place it right at the gum line. You could say CEJ, and you're just measuring in between 3 and 14 or A and J. what's the shortest distance between those teeth right at the gum line, or CEJ. And yeah, Bowley gauge is wonderful. Now, if you don't have the Bowley gauge, or the child is 5 and you're worried about coming at them with that pointed tool and looks like a pitchfork, you could use a cotton roll. You know, the cotton rolls that we have in the office, they're all, and it looks like you've got one there handy. So
Wow.
no, oh my goodness, I thought you were going to grab a cotton
Go
roll and
ahead.
show it to everybody. So the cotton rolls, they measure 37 millimeters. So what a great opportunity. So a cotton roll that's 37 is really good for any adult. You know, once you're 8 and 12, when you're thinking about 35 and 40, right? If an 8-year-old's supposed to be 35 and a 12-year-old's supposed to be 40, you take your cotton roll at 37, you get a good estimate. And if you think, oh, I don't want to estimate that, it seems off, just cut some off and check again, because then you can always measure your cotton roll on the table and then go and say, oh, so a cotton roll is a really nice, easy way, beginning with a 37 millimeter cotton roll, and you can trim it to 30 if you want to measure a kid. Then it's soft and it tickles and it's easy to do. So I use a lot of cotton rolls for measurement.
So this is just a little my functional therapy hack that I have. If you do not want to buy extra cotton rolls, we already use the medical tubing. I just cut the tubing to the exact 37 millimeter, or 30 for children. So I have that in the pack already. So if you want to save on an extra tool, you can try to reuse the tools that you already have to accomplish what you're trying to do. Anyways, Dr. Mark just asked on Facebook, is there any removable appliance at all you would recommend for when you get to the expansion goal?
Well, if it's kids, we move to any type of myofunctional guidance appliance. And so because I do use a lot of MyoBrace, it tends to be the default. So for children coming out of expanders, the biggest priorities after expanders are going to be working with the myofunctional therapist and having a myofunctional guidance appliance. And MyoBrace is one of those. So those are the two things that, should probably happen. Now, if they're older, if it's a teen and they're coming out of expansion, we're probably going to go to clear aligners, because we might still be then moving. Let's say we meet the child at 12 or 13. So they get into expanders, but now we've got teeth to coordinate. So we might not get the MyoBrace there. We might go from expanders, fixed expanders, to we might go right into aligners, because aligners can continue the pathway for wider and forward and growth and development. So you can use aligners for a little while after that. The best thing to do is avoid anything that is a fixed retainer in any human being who's still growing. And so basically under 21 shouldn't really have anything fixed in there holding things, because then you're freezing them at that point and they should still be growing bigger and bigger and bigger. I'm not opposed to the lingual bar at the very end later on. If you have a teen who's all done and their teeth are very nice and you don't want to see a little relapse in the lower anterior teeth, I don't mind putting that little lingual bar there, because the idea of wearing a clear aligner type retainer indefinitely for tooth positioning, that can be daunting through college. And so, yeah, if you want to protect for a few years while they're in high school or college and put a lower lingual bar, not opposed to that. But it means you've already delivered all of the growth and development in the jaws, and you could look at a Panorex and see how the wisdom teeth are parallel and are going to come in. Then you could put that in and have a little safety net. So that'd be the only point at which I would say, okay, lower lingual bar, 22 to 27 at the very end when they're older, an older teen, that'd be fair enough.
Perfect. Angela was just commenting that her son's expander just fell out 2 weeks from today. He'll get braces, but I need to remeasure his palate. So she ran and did it, and it's 33.7 millimeters. Insert eye roll, she said.
33. Oh yeah, 33 at 11.
Mm-hmm.
Right. So we want to be 40 already. And I can guess already, and maybe she can comment, he probably only had an upper expander, because an upper expander doesn't really give you much gain. And I think if we had the previous model before the expander, or when the model was, or when the expander, that child was probably 30 to 33 already. And so to be at 33 now, I would like to check, have her check. Maybe she can request, what was the original width, or if they might have a model that you can check to know, was there accomplishment with the expander, But I'm willing to bet it was just an upper only. That child probably did not have a lower.
Dr. Scott asked, do you
There's the
ever
original
use...
width popped in.
Let's
Yeah,
see.
30. I just
30?
saw it come up there. 30 millimeters original and only an upper. So here's the thing now. At 33.7, if that child is 33.7 now, each month that goes by, that number is going to slowly decrease, because with an upper only and not attending to the breathing frenum musculature, the musculature is working against that. So at age 11, this is still immature bone. So if we were following that child month by month by month, the 33.7 is going to decrease. And that happens almost, across the board. If we wait an amount of time long enough, that child probably works their way right back to 30. And so 30-31 is coming. Braces don't really continue wider. Braces aren't going to beat the tongue and cheeks. So if the tongue is weak and the cheeks are strong, and when you put braces in, you're activating the histology. That mouth will collapse again. So the braces aren't going to give you width. They're going to guide you right back to 30, because you're going to keep histology active, but you're going to have muscles on the outside stronger. So the back teeth are not going where the braces and wires want you to go. The back teeth are going to go where the cheeks want them to go. And so if your tongue is not doing its job pushing out, and the cheeks are doing their job, meaning they're working overtime now, here comes the collapse. So that child's going to finish at 30 or 31 with the braces going back in. So we meet an 11-year-old at 33 millimeters. You know what they're getting? An upper expander, a lower expander, and we're going to take them to 42. And when they get to 42, we would think about, okay, well, if you're 42 and now you're 12 years old, do you want to have braces or you want to have clear aligners? But in that time frame, you'd have had your nasal breathing, your frenum released if you needed it, and the myofunctional therapy to deliver the breathing and musculature. If you deliver the breathing and musculature, there's nothing wrong with braces at 13 or 14 to finish tooth alignment. So if you have the foundation right, and you're over 40 millimeters, and you have your breathing and musculature correct, you can use braces at 13, 14, or 15. I do a lot of that. I don't mind braces as long as they're not alone, because braces alone are not helping. Braces alone come with a lot of relapse. Those mouths collapse, and it gave rise to right now a dozen different clear aligner companies all making billions of dollars. Why? Because nobody who wore braces has a successful result later on in life. They all fall apart. So you have the opportunity to work on the cause. So you get your breathing and musculature correct. You get that child expanded up to about 42. You switch them into braces for final tooth alignment. And for those kids, they get braces for just a few months.
Perfect. Since you mentioned, what is the percentage of your patients that you refer to myofunctional therapy?
So we refer almost all of the kids. We get a lot of success kids going. Adults, I still struggle getting adults to go to the myofunctional therapy. I'm working on that. I'm trying to get that to be a higher number. So most children need a myofunctional therapist. I do not do it in my own office. So we do very little to get the ball rolling, a few little things they can start at home. But we encourage them to, yes, meet our myofunctional therapist. It's a separate appointment. They have to go to their office. And then if they can do it virtually, that's wonderful. So it's nice to have a virtual opportunity to do the myofunctional therapy. It saves people trips. They don't have to go running around. But you probably need a child who's a little bit older that can work through a computer with someone. So there's probably an age issue there. But most of the children we meet need a myofunctional therapist. And then second to that, most of the kids we meet need a frenum revision. And that comes from just starting to measure it. Now, if you go back, I could do this again with the frenum. Take me back 15, 18 years ago. And if you asked me how many kids need a frenum revision, I'd say, what is that? None of them. I'm 12 years into practice. Hey,
they don't have any issue speaking.
Yeah, I'm 12 years into dental practice, and this is 18 years ago. I know I'm doing all this math. I'm sorry for all the math people, but it is my 29th year in dentistry. So I'm 29 years since I graduated dental school, and my first decade was none of this. So that's why I keep saying 10 and 18, blah, blah, blah. But the idea is, yeah, there's a point in time where I didn't know what a tight frenum was. So did I know the word? Yeah, I knew the word, right? We learned the word. I didn't know what I was talking about then. Now you realize, you start measuring, and you have Dr. Irene Markazan protocol. You got a Dr. Kotler protocol. You got a Dr. Zaghi protocol. There's at least 3 that are already documented, published, and objective measurement related protocols to diagnose a frenum, restriction. So you have ways to do it. Then you start doing those and you realize, oh yeah, most kids are tied and restricted. And of course, guess what? Tongue restriction is a risk factor for underdevelopment. And underdevelopment is your risk factor for sleep disorder breathing. So there you have it. Those 3 dominoes are all together. Tongue tie, underdevelopment, and sleep disorder breathing, all risk factors right there in a row. So now you measure all the kids and their frenum. If most kids have a frenum issue, guess what they need? Automatically, you need myofunctional therapy, because no one should be getting a frenum revision without myofunctional therapy prior and after. And that becomes a 6 to 9 month process. You got to have some time with the
Yeah.
myofunctional therapist. Then you get your revision done. And the day you get your revision done, if not that day, the next day, you're back in that office working it again because you got to go months after that to get it right. So you have the overwhelming need for myofunctional therapy in, I would say, almost all of the kids that we meet. Once in a while, there's a child who if we gave them a few little exercises and they were a mild type of case, they'd be okay. But with each year that goes by, the kids are all going because it's necessary. So we're at the point where we recognize that children need a myofunctional therapist.
Oh my gosh, it's 9 o'clock.
What?
I know you can go so fast.
I
You know
know.
why? Because your husband's taking care of your baby.
Yeah, but not in California. We still have 3 more hours in California.
Oh my goodness, I cannot believe that we reached our hour. We still have so many questions. We haven't even shown our visuals. that we
Sounds like we'll have to have a
We'll have to
follow-up.
come back, Renata.
We might need a
All right.
follow-up.
Oh my goodness. Let's do a last question, please. Thank you. Dr. John, yes. I want to see you guys hitting like on the Facebook. That will tell the algorithm to share this with other people, to show up to people who are interested. Dr. John Comisi said, so very glad you evolved to bring this forward, Ben. So much to learn, even after almost 40 years in the profession. And Dr. Bass Sohail said, do you like the Mile Munchie? That's the last question.
The Myo Munchies. You know, I don't use them, but again, I do very little myofunctional therapy because I'm referring it out. So I have 5 or 6 very, qualified myofunctional therapists within 1 hour of my practice. So I can send them out. I don't use them. That's the honest, but it's not because I don't like them. It's because I'm not really doing myofunctional therapy. I'm sending those kids out. Yeah, send them to the myofunctional therapist. If the myofunctional therapist likes the Myo Munchie, then use them.
There's so many questions. Can I ask a couple more?
Yeah, sure. We'll try to do rapid fire, get a few more.
Yes. What if someone, a 14-year-old, is in traditional braces for the past 1.5 years and is just now looking into myofunctional therapy? Can I help her with her tongue thrust?
Yeah. You're never too late. Just get started, because if we don't correct the breathing and musculature, guess what happens when the braces come off? It's going to collapse again. So, then you get to be clear aligners when you're 25 or 30. And then guess what happens if you get clear aligners when you're 25 or 30? You get them again when you're 40 and 45, because eventually you'll stop wearing that retainer. They'll shift again and you get them twice. So depending upon the age you meet the patient, we have the 60-year-olds coming in who had braces 2 or 3 times and they tried clear aligners and now they're coming back. I need them again. So yeah, why not work on the muscles and the breathing? So that 14-year-old should be working with a myofunctional therapist, and someone should do the frenum evaluation to see, is there a restricted frenum that could be released? And then you get those 2 things in place, things start doing, you a whole lot better with myofunctional therapy. It's the answer.
Perfect. Alyssa just said, yes, please have Dr. Miraglia back. I learned so much. Thank you. Yes, I'm not going to get to any more questions because we're past our hour. Guys, this has been wonderful. Thank you so much. Make sure that you share this live if you liked, and if you think that other professionals should listen to this. Dr. Ben and Lauren, you guys are wonderful. Thank you so much for joining Airway Circle in this fight to raise awareness of airway issues. You guys are wonderful. Thank you.
Thank you. Thank you for having us.
Thank you very much.
Of course, everybody have a wonderful night, and we'll see y'all tomorrow at 1 p.m. Eastern Standard Time with Dr. Danya Tamimi. And we actually have a guest. She's not a guest speaker. She's a guest host. She's going to host it with me. So I cannot wait for you guys to see who it is. It's going to be wonderful. We're going to be learning about CBCTs and TMJs, sleep disorder breathing. So Facebook Live tomorrow at 1 p.m. And I will post on our group right now the questions for the Instagram takeover. So go over there. If you know the answer, you get a prize. Thank you guys so much. Have a wonderful night, and we'll see you later.